Adolescents. Thanks, Barry. Don't you love Barry? What a force. So it's interesting. I'm part of a translational research group, but I'm the clinical end. So I'm actually at the symptom anxiety disordered kid end of that translational work group. And so that's really the leadoff lecture. We're part of a basic science team, but I'm the clinical tip of that team, if you will. And we have so little time and so much to cover. This is my disclosures. My most complicated relationship was with the Tourette Syndrome Association, where I get royalties from books and get honorary and stuff like that for being on their medical and scientific advisory boards, but also speak for them through a Center for Disease Control grant. I'm going to talk a little bit about the context in which we think about anxiety in kids with developmental disabilities, then describe the disorders, but more importantly, talk about the symptoms, because the disorders really don't come alive. It's really the symptoms that kind of lead you to the diagnosis of an anxiety disorder. And in children who are maybe nonverbal or have low verbal output, these are youngsters who aren't going to actually talk about their anxiety. So you've got to look at those youngsters in a completely different way in order to understand whether or not they have an anxiety syndrome. A very brief review of treatment, and then talk a little bit about the challenges of looking for anxiety in developmentally disabled children. There's two kinds of ways people look at anxiety in autism. When I was first trained, anxiety was considered to be a kind of central feature of a certain number of kids with autism, that it was actually part of the disorder itself. Increasingly, what you're seeing in clinical practice is that we are beginning to think about anxiety as a condition that occurs in many typically developing children, but also occurs in children with developmental disabilities. Our biggest challenge over the past 5 years in terms of clinical treatment research is how the heck do you evaluate and rate anxiety severity in a nonverbal child who has a multiplicity of symptoms? And essentially what's happened is they haven't been able to do it yet. So the treatment trials have all focused on anxiety as a symptom kind of key to autism. And so the sampling frame, or who you recruit into the study, usually includes all children, only a minority of which would actually have an anxiety disorder, meaning that you'll have a very difficult time in a treatment trial identifying a difference between the active treatment and the control treatment, simply because you don't have many kids in the sample who actually have an anxiety disorder per se. So that's our fundamental dilemma, if you will. Like I said, and I tend to think in terms of lumpers and splitters, the field has been a lumper kind of field for many, many years, bringing it all together, seeing it all as kind of core feature of autism. By the end of the lecture, I think you're going to find out that I'm a splitter. I'm looking for syndromes that sit within kids who are developmentally disabled, and then offering treatments that we know work in typically developing kids to the kids who have autism spectrum disorders or developmental disability. So what do we look for? Well, you know, child psychiatry can be extremely complicated, but there are just a few disorders that we actually have to look for that we have really good treatments, evidence-based treatments for. So we look for ADHD symptoms, we look for anxiety disorders, which is what we're talking about today. We see teenagers who actually experience depression. Very few kids actually go on to develop mania, but it can be a life-altering condition for kids with developmental disabilities when they develop bipolar disorder. And there's, again, a small group of kids who actually develop psychotic disorders. How do we figure this all out? Well, probably the first and most important thing is when you see a youngster who's had a onset of a condition, if you will, who is either typically developing or developmentally disabled, is to get that family history. And when you have a positive family history for one of these conditions, that is a terrific clue that that youngster who's all of a sudden had a change in their course of illness, that the change in course of illness may actually be due to something that runs in that family. The other thing I think that's important is when you look at kids, the parents of kids who are developmentally disabled, is many of their parents have conditions, but they're at the subsyndromal level. So they may have mild anxiety. But the other thing, at least in my experience with the developmentally disabled, is it's often bilineal, meaning mom's got something and dad's got something. So they bring something to the party together. And it's in the mood disorders, anxiety disorder spectrum. And when kids get double doses of the mild things that mom and dad have, you oftentimes begin to see the fuller, more robust syndrome in that youngster. I'm glad I'm making some sense. I got some people smiling. I think they may be thinking about themselves. So for me, this is the absolutely critical diagram for how I figure out what a nonverbal youngster is experiencing. Because these conditions that we treat present at specific times in development. So PDD, abuse and neglect, often knocks kids off their normal developmental trajectory very early, preschool era. Anxiety disorders present for the first time and most commonly between 6 and 10. So if I see an 8-year-old who's functioning normally until they get to be about 8 years of age and all of a sudden they're not functioning within their normal routine anymore, I am alerted to the fact that the one condition that can knock a kid off his developmental trajectory is an anxiety disorder or OCD. If that child is 14 or 15, 16 years of age and they're falling off their developmental trajectory, I think about depression. And as they get older, into their late teens, I think about bipolar disorder. Now, depression can happen in younger kids, but it's quite rare to happen in 10, 11, and 12-year-olds. In 10, 11, or 12-year-olds, it's usually, the affective disturbance is usually anxiety. We hear a lot about prepubertal bipolar disorder. It's extremely rare. The most common presentations are really later in development. So these are the anxiety disorders. I call them the flavors of anxiety, if you will. And, you know, kids have fears, obsessive compulsive disorder. I bracket these three conditions because in most clinical treatment trials, we treat them as one, in part because they commonly overlap and are comorbid, and they're also really tricky to differentiate from each other. So separation anxiety is, you'll see in your handout there's a description of the condition, but these are kids who really worry about being separated from their parents or caretaker. Something bad's going to happen to their parents or something bad's going to happen to them. Well, if you ask that child why they don't want to go to school, they say, I'm worried too much about my mom, I don't want to leave my mom. Generalized anxiety kids, if you ask them why they don't want to go to school, they'll say things like, well, I'm worried today because there's going to be thunder and lightning this afternoon and I don't want to go outside. And if you ask the socially anxious child why he doesn't want to go to school, is that he's going to have to read aloud in his reading group. So all three kids don't want to go to school, right? But each one of those syndromes has a particular way of leading to school absence or school refusal. And sometimes what you see is the kid will give you all three reasons for not wanting to go to school. He's going to miss his mom, he's worried about thunder and lightning, and he's really afraid of standing up in front of the class and reading aloud. We have a very active program here in looking at post-traumatic stress disorder, not really something I'm going to talk about today. And as you move into the late teens and adult populations, you begin to see panic disorder. So what are the core features of anxiety? There's really three. Hypervigilance. People with anxiety are chronically scanning their world to try and figure out where the new thing is. And when they see that new thing in the environment, like this event for most anxious people, oh my gosh, there's too many new things right here, right now to look at. But they're looking for new things. They fix on what is ever novel in the environment, and then they interpret it as threatening. So it is a chronic position that they face the world with. The other thing that they do, which is really the crippling aspect of anxiety, is avoidance coping. So their primary strategy is to evade or avoid. And the one thing that they engage their parents around is facilitating their avoidance. So one of the things that we see with modern parents is they are totally committed to their children's happiness. Except if you have an anxious child and you're totally committed to their happiness, you might actually facilitate their avoidance over an extended period of time, so that these youngsters, instead of developing rich, robust coping strategies, they actually become a coping one note, if you will, using primarily avoidance strategies, engaging their parents in avoidance, and in that process beginning to restrict their world and make it much smaller.